Adjuvant salvage, PSA nadir is 4 weeks after radical prostatectomy, 2 to 3 years after external beam, and 3 to 4 years after brachy. You can see a PSA bounce, which is a transient rise in PSA, which is usually less than 2 nanograms per milliliter. For brachytherapy, there's a 15 to 30% incidence, 90% of which occurs in 3 years. External beam, it's much less. There's a 10% incidence, median time is about 9 months. Failure after EBRT. Per RTOG, it's 3 consecutive increases in the PSA after radiotherapy. For clinical trials, the date of failure should be the midpoint between the post-irradiation nadir PSA and the first of the 3 consecutive rises. Phoenix is the new standard after EBRT. It's the nadir plus 2 nanograms per milliliter after EBRT with or without hormonal therapy. The date of failure should be at call, not backdated. Management, adjuvant radiation indications used to be PT3, meaning extracapsular extension or seminal vesicle invasion, positive margins, and undetectable PSA. Treat as soon as 2 months post-op, but wait for up to 6 months for urinary symptoms to stabilize. Salvage indications for biochemical failure after surgery, PSA greater than 0.2 nanograms per milliliter on 2 occasions, PSA greater than 0.4 nanograms per milliliter once, detectable PSA after being undetectable, additional workup, PSA doubling time, CT or MRI, bone scan, prostate bed biopsy if imaging suggests a recurrence. Post-prostatectomy, PSA half-life is 2 to 3 days. Post-op PSA should be within 0 to 2 weeks. Evidence for adjuvant, the first is the SWOG 8794 trial. This is PT3, positive margin, positive seminal vesicle, 473 patients, randomized control trial of immediate radiation, 60 to 64 gray versus OBS, basically immediate versus delayed. Median follow-up was 13 years. Results, metastasis-free survival at 10 years, 71 versus 61%. Adjuvant radiation improved biochemical control by 20% in overall survival, median 15.2 versus 13.3 years. Overall survival at 10 years, 74% versus 66%. There was increased toxicity. Stricture was 10% versus 18%, rectal 0% versus 3%, incontinence 3% versus 6.5%. Overall HR 2.0. Every subset benefited. The other is EORTC, Ball, Lancet 2012. Post-op RT improves progression-free survival and local control at 10 years, but not distant Mets or overall survival. Salvage, Stevenson, JAMA 2004. 500 patients with salvage radiation after radical prostatectomy. Predictors of progression after salvage radiation were Gleason 8 to 10, pre-radiation PSA of greater than 2, negative margins, PSA doubling time of less than 10 months, or positive seminal vesicle invasion. After salvage radiation, progression-free survival at 4 years was 45% overall and 77% for patients without adverse features. Patients with Gleason 8 to 10 or short PSA doubling time could achieve complete response if radiation was done early. This was updated in 2008 and ADT was found to be significant. TROC, JAMA 2008, RTOG 9601 by Shipley. Basically adding 24 months of ADT during and after salvage radiation statistically significantly improves overall survival, distant Mets, death from prostate cancer, local recurrence, and tumor progression without added toxicity. The biggest new ones are obviously going to be radicals, which is looking at adjuvant or salvage. This is 1,396 men with intermediate to high-risk prostate cancer after radical prostatectomy with a post-op PSA of less than 0.2 nanograms per milliliter and one or more of the following, either PT3 or T4 disease, Gleason 7 to 10 disease, preoperative PSA greater than 10, and positive margins. Randomized either adjuvant or early salvage at PSA failure, which is defined as PSA greater than 0.1 nanograms per milliliter and rising times 2, or any PSA rising times 3. The radiation was 66 gray and 33 fractions, or 52.5 gray and 20 fractions. Whole pelvic RT at 56 gray was optional. ADT none versus 6 months versus 24 months. 8-year biochemical progression-free survival was not different. Distant Met outcomes are pending. GU incontinence 5.3 versus 2.7%, and urethral stricture 8% versus 5%. Results from radicals: there was no difference in biochemical control. There was worse toxicity in the adjuvant radiation therapy arm. Raves by knee bone: 333 PT3A or B or positive margin, PSA less than 0.1. This is a non-inferiority trial. Adjuvant radiation 64 gray, or wait and see salvage radiation 64 gray at PSA greater than or equal to 0.2. Results closed early due to a low rate of events. Adjuvant versus early salvage was not found to be non-inferior due to low rate of events. Results favorable in both arms, with salvage 50% avoided radiation and GU toxicity was decreased. The artistic meta-analysis of radicals raves in Jetug AFU 17 basically looked at adjuvant radiation versus salvage radiation and showed biochemical failure was defined at 0.4 or greater. There was no difference in event-free survival, biochemical progression-free survival between adjuvant and salvage. Salvage spared patients from treatment and reduced adverse events and thus is preferred. Caveat here is 78% were Gleason 7. SAC 0910 by Gajar G.U. Askew looks at salvage radiation dose. This is 350 patients with 2 rises in their PSA and PSA greater than 0.1 or any PSA after 3 rises. Status post-radical prostatectomy with nadir. They either got 64 gray and 32 fractions or 70 gray and 35 fractions. 3D or IMRT results 6-year biochemical progression-free survival 61 to 62%, not different. No difference in progression-free survival, overall survival, or time to ADT. Coport is ongoing. This is looking at salvage hypofrac, T2 to 3 with or without positive margin, 66.6 gray and 37 fractions versus 65.25 gray. ADT less than 6 months allowed. Whole pelvic RT is not permitted. METs, Oriole, SBRT to all oligomets sites, reduced progression of new lesions and led to T-cell proliferation. Overall survival is not an endpoint. Stampede, low metastatic burden of prostate cancer, had an 8% overall survival improvement with prostate RT. 3-year overall survival of 81% with local prostate RT and standard of care versus 3-year overall survival of 73% with standard of care alone. Let's talk about technique. Dose 64 gray per NCCN based on SAC 0910. If there's a positive nodule in the prostate bed, boost to 72 gray. SIM, CT SIM, same as for definitive, details above. MRI fusion or urethrogram to identify the anastomosis. Contour via RTOG guidelines, review surgical pathology volumes. CTV prostate bed is defined as follows. Superior is where the seminal vesicles or the vas deferens are, or 3 centimeters above the pubis. Inferior is the top of the penile bulb, or 1 centimeter below the vesicourethral anastomosis. Above the pubic symphysis, you contour into 1 to 2 centimeters of the bladder. That's your anterior border. Your posterior bladder is your mesorectal fascia. Laterally, you go to sacro-rectogenital pubic fascia. Then below the pubic symphysis, anterior is just going to be just posterior to the pubic symphysis. Posterior is going to be anterior border of the rectal wall. Lateral is going to be the medial border of the levator ani and include retained seminal vesicles if they're involved. PTV is a 1 centimeter expansion, 6 millimeters posteriorly. Consider including pelvic lymph nodes per the SPORT trial. There were 3 arms with this: prostate bed only, prostate bed plus ADT, prostate bed plus whole pelvic RT plus ADT. 5-year freedom from progression for prostate bed only was 71%, prostate bed plus ADT was 83%, prostate bed plus ADT plus whole pelvic RT was 89%. The distant METS rate was also better. Set up daily cone beam CT. Dose constraints. Bladder minus CTV should be V65 less than 50%, V40 less than 70%. Rectum V65 less than 35%, V40 less than 55%. Toxicity follow-up outcomes. Early salvage is better when PSA is less than 1 and associated with prostate cancer specific mortality benefit and retrospective review. Outcomes: biochemical progression-free survival for a PSA of greater than 2 is 20%. This is at 4 years. Biochemical disease-free survival at 4 years for PSA of less than 2 is 50%. Adjuvant salvage RT, there's higher risk of impotence, incontinence, stricture, grade 1 to 2 GI, GU toxicity, 20% versus 5%. Urethral stricture, 18% versus 9%. Toxicity of salvage radiation, GI, 5% need lasers, 10 to 20% with mild spotting, less than 1% for all other toxicities over radical prostatectomy alone, 30% increase in erectile dysfunction versus radiation alone, so about 60%. It's a good kind of question about which patients need nodal radiation, the high risk, high percent lymph node positive, low percent metastatic disease are most likely to benefit from extranodal or elective nodal radiation. How I treat post-prostatectomy in 2020. This is all dependent on a PSA of less than 0.2, between 0.2 and 0.5 or 0.5 and 2. If the PSA is less than 0.2 and the Gleason is 6 or 7, you observe If it's 8 to 10, consider ART only if multiple T3B, high Gleason score greater than 0.6 or lymph node positive. If their PSA is between 0.2 and 0.5, Gleason score 6 to 7, do ESRT. Gleason score 8 to 10, SRT plus or minus ADT. And the rest of these as follows. This is how Cleveland Clinic delivers prostate SBRT in 2020. They do rectal spacer plus fiducial markers with real-time tracking, MRI fusion, VMAT-based urethra-sparing SBRT. Cleveland Clinic SBRT DVH goals: prostate plus seminal vesicle PTV 3 millimeters, 36.25. Prostate excluding urethra should get 40 gray. DIL if visible 45 gray. Urethra less than 40 gray. Bladder less than 39 gray. Anterior rectum less than 39 gray. Lateral rectum less than 20 gray. Posterior rectum less than 15 gray.